metastatic castrate-resistant prostate cancer, sequencing AR-targeted therapies, chemotherapy, and others. First of all, allow us to start to understand the concept of castrate resistance. Castrate resistance consists of three parameters. Number one is progression of disease, which can be either biochemical or radiological. Number two is adequately suppressed serum testosterone. And number three, the patient must be receiving either surgical or medical androgen deprivation therapy. The combination of these three parameters results in a proper diagnosis of castrate-resistant prostate cancer. However, there are some emerging concepts, and this is a space that is to be watched out because the definitions may change in the future, as the cutoff for the rise in PSA may change from 25 to 50%. Metabolic imaging may actually play a greater role, plus whole body MRI as compared to standard CT staging with RECIST 1.1 criteria, and perhaps the replacement of estimation of total serum testosterone with serum free testosterone or serum luteinizing hormone. So these emerging concepts may actually alter our understanding and subsequent definition of castrate-resistant prostate cancer in the future, and that is a space that we should watch out for. In understanding sequencing therapies in first-line metastatic castrate-resistant prostate cancer, we have got to understand how the treatments were actually administered in the hormone-sensitive prostate cancer space. In terms of the therapies targeting MHSPC, from the 1940s, it was ADT alone. Since 2015, it was ADT plus docetaxel. From 2017, it was ADT plus ARSIs. And from 2022, it was the triplet consisting of ADT, docetaxel, and ARCI. So the therapy that was then constituted for the patient in the castrate-sensitive phase would then allow us to determine what would be the appropriate therapy to be used in sequence in the castrate-resistant phase. So let's look into the first two scenarios, which is patients receiving prior ADT with or without docetaxel. So we then divide them into those with HRR mutation or BRCA mutation and those without. So let's look into the first group, those without HRR mutation. So the role of chemotherapy in castrate-resistant prostate cancer was established very early on with the trial text 327, comparing 3-weekly docetaxel with weekly docetaxel and mitoxantrone with prednisolone. And this particular study actually showed that the 3-weekly docetaxel was superior for patients who were previously treated with ADT alone. And using the 3-weekly docetaxel as the standard of care, the Fastana study actually compared the non-inferiority of cabazitaxel, and that was very well established in comparison to docetaxel. But this study also showed that the use of a lower dose of cabazitaxel was equally effective, but resulted in a better safety profile. And with the rise of the use of docetaxel in the castrate-sensitive phase, so TROPIC and CART trials actually looked into this subset of patients who received prior docetaxel, where in the TROPIC trial, cabazitaxel was superior to misodantrone, and in the CART trial, cabazitaxel was superior to androgen receptor signaling inhibitor. But in a more recent retrospective review of looking into patients who have received prior docetaxel, the re-challenge of docetaxel was associated with a better outcome as compared to cabazitaxel in terms of overall survival and time to next systemic therapy or death. So this has now renewed interest in re-challenging patients with docetaxel rather than jumping onto cabazitaxel upfront, so that we can then sequence these drugs and stretch them across the treatment landscape for as long as possible to maintain patients on effective treatments to prolong their survival as a whole. Moving on to ARSIs in metastatic castration-resistant prostate cancer, the COU 302 trial actually looked into population of patients who did not receive prior chemotherapy and actually showed that abiraterone was superior to prednisolone. And a similar outline was actually obtained from the PREVAIL trial, that enzalutamide was superior to placebo in patients who did not receive prior docetaxel. For patients who have received prior docetaxel, the COU-AA 301 trial actually showed that abiraterone was superior to placebo and prednisolone, and this particular benefit was sustained across all patient subgroups. We can't complete the talk without talking about radium-223, although radium is not available and accessible in Malaysia, but the option that it offers is something that we have got to know as specialists treating prostate cancer. So PEACE-3 is a study that looked into enzalutamide plus minus radium-223 in patients with castration-resistant prostate cancer, and this was a positive study showing that the addition of radium actually improved progression-free survival and overall survival. And that results in the particular diagram that shows that if patients have received prior ADT with or without docetaxel, in the absence of a HRR or a BRCA mutations, patients can go on to receive an ARSI, chemotherapy, or where available, enzalutamide with radium-223. Now let's switch focus to patients with HRR mutation or BRCA mutation. So the evidence for this is derived from 3 trials looking into 3 PARP inhibitors. The PROPEL study looked into combination of abiraterone with olaparib. The TALAPRO-2 study looked into enzalutamide with talazoparib. And the MAGNITUDE trial looked into combination of abiraterone and niraparib. And all these 3 trials were positive, suggesting the improvement of progression-free survival and a trend towards improved overall survival with the use of a PARP inhibitor in combination with ARSI. And this applies for patients who have received ADT alone or ADT with docetaxel in the castrate-sensitive phase. Now let's move on to a slightly more familiar ground where patients receive ADT and ARSI in the castrate-sensitive phase, which is commonly done in our setting today. So again, let's divide them into those with HRR or BRCA mutation and those without. So in the population of patients who have received ADT and at least one ARSI in the past, who are still considered to be taxane sensitive, whereby if they have received taxanes, they must be more than 12 months disease-free. And PSMA-4 study actually looked into patients who were candidate for an ARSI switch. So if they were on abiraterone, that you would actually consider to switch them to enzalutamide and vice versa. And these patients were then randomized to receive lutetium PSMA 617 therapy versus the ARPI or ARSI change. And this study actually showed that there was a significant improvement in event-free survival for patients who received the lutetium PSMA therapy. However, if the patients were chemotherapy naive, right, and have received prior ARPI, who were not considered to be candidates for an ARPI or ARSI change. So the Pluto study actually looked into randomizing patients to receive lutetium PSMA 617 versus docetaxel. And this study actually provided a contradictory outcome to what was seen in PSMA-4, where patients receiving docetaxel seemed to be having a better progression-free survival, and the trend in overall survival tend to favor a sequencing of docetaxel followed by lutetium PSMA in the second-line setting for castrate-resistant prostate cancer. But of course, both these studies have got their strengths and weaknesses, and there are actually a lot of points to be considered before the outcomes of these studies can actually be taken into consideration for establishing lutetium PSMA sequence in patients with metastatic castrate-resistant prostate cancer. However, its role in patients who have received prior docetaxel or prior ARSI cannot be negated. So now let's look into patients who have received prior ADT and ARSI, who are now castrate-resistant and harbor HRR or a BRCA mutation. So the evidence for this group of patients are derived from the PROfound study, where in the cohort A, patients with HRR mutation were randomized to receive olaparib versus physician's choice of treatment. The progression-free survival based on imaging, as well as interim overall survival, was significantly better with the use of olaparib monotherapy. And something very similar was also discovered in the Triton-3 trial, whereby patients were randomized to receive either rucaparib versus physician's choice of treatment. And the patients who received rucaparib actually had an improvement in terms of progression-free survival. And there was a trend towards an improvement in overall survival. Now comes the more difficult question. So if the patient has received a triplet therapy with a prior ADT, ARSI, and docetaxel, now what would be the appropriate sequence for them in the castrate-resistant phase? Unfortunately, there are no randomized phase 3 data to actually support these recommendations. The evidences that are actually derived in this particular chart that is here out here is based on consensus guidelines. And this is as per what has been decided in APCCC 2026, which also concurred to recommendation from the prior APCCC. So in this particular consensus guidelines, it has been suggested for patients without HRR mutation who have received a prior triplet therapy, lutetium PSMA therapy or chemotherapy are reasonable options. Whereas if the patients harbor HRR or a BRCA mutation, monotherapy with a PARP inhibitor is something that is recommended. We do not know if there will be an upcoming phase 3 randomized clinical trial to actually answer this question, but perhaps this kind of consensus guidelines are the best sets of evidence that we have to guide our practice in the practice sessions that we have in the current time. And of course, most of our patients with prostate cancer are elderly, and many of them do have a lot of comorbidities, as well as many other issues to consider. And there are SIOG recommendations to look into the treatment of metastatic castrate-resistant prostate cancer in the elderly, whereby if you are to use chemotherapy, perhaps you want to use a gentler combination, such as a 2-weekly docetaxel or the lower dose of cabazitaxel. Abiraterone and enzalutamide are both suitable, although enzalutamide is sometimes associated with an increased risk of CNS side effects. Optimal sequencing regime, whether you use chemotherapy first or ARSI first, still remains a topic of debate, including in the elderly population. And there has to be a careful evaluation of drug-to-drug interaction, as patients will be on polypharmacy for various comorbidities. Early palliative care treatment, interventions, and referral is very much indicated. And of course, for all patients, not just the elderly, exercise intervention is very much recommended. So let's just recap. This is what guidelines tell us for patients who have not received prior docetaxel or novel hormonal therapies, patients who have received novel hormonal therapy or docetaxel, patients who have received hormonal therapy but no docetaxel, and these would be their recommended approaches. And regardless of these particular approaches, there are some recommendations, such as the use of disease-specific treatments, such as syphilis and LT. For oligometastatic or oligoprogressive disease, the utilization of local therapies. For symptomatic bone predominant metastasis, the use of radium-223 and or bisphosphonates and other form of bone targeting agents, and molecular biomarker-directed therapies such as the detection of MSI status for the use of PDL1 inhibitors. Now let's talk about beyond first line. So the treatment beyond first line in metastatic castrate-resistant prostate cancer would depend on the treatment the patient received in the hormone-sensitive phase, the HRR mutation status, and the first line treatment that was received in the castrate-resistant phase. And in addition to that, you would also need to ask yourself, what treatment option is available? What treatment option is accessible? What treatment option would be tolerable? And more importantly, what does the patient want in terms of their symptom goals as well as disease control goals. So allow me to illustrate the complexity of treatment of a prostate cancer patient today with a gentleman whom I have treated over the years. So he's now 79 years old. He was initially diagnosed about 10 years ago with the adenocarcinoma Gleason 3 plus 4 with no HRR mutation. He initially presented with a localized disease, which was then managed with radical prostatectomy. And he had a biochemical recurrence a lot later, which was managed with an ADT. And he actually progressed with a non-metastatic scenario, which we call as a non-metastatic castration-resistant prostate cancer, where he then went on to receive ADT with apalutamide. And upon further progression, and when it became radiologically evident disease, he then received first-line cabazitaxel. And upon progression, he then received lutetium PSMA therapy. And he has just completed his 4th cycles of lutetium PSMA therapy, and he remains relatively well. And if he progresses further, the lines are a lot blurred as to what could then be offered to him as the next treatment. So as you would see the case illustration right about here, it is about finding the right treatment to address the needs of this patient based on their presentation at that point in time. And as time progresses and as evidence also mature, I'm sure we would be able to identify more treatment options to be offered to this patient, although right now it seems rather limited. And that actually brings me to the later part of my talk, which is on looking into emerging therapies. Now, these are promising landscape for options of treatment that we would have for treatment of castration-resistant prostate cancer in the future, either by targeting the AR pathway, targeting the PIK3-AKT-mTOR pathway, the epigenetic EZH2 pathway, CYP11 inhibition, PROTAC, which is protein degradation of the androgen receptor, identification of the MSI status, or identification of DLL expression, especially in small cell carcinoma transformation. There are targeted therapies looking into these particular approaches, and these are very much in early phases of study, and we would be looking into these studies coming into the castrate-resistant phase as standard of care in the future. And looking into immunotherapy, the targets such as KLK2, STEAP1, STEAP2, DLL3 in neuroendocrine carcinomas are all very relevant targets to consider. And there are ongoing trials looking into monotherapy with immunotherapy or combination with ARPIs. And again, this is another space to look out for. And the outcomes of these studies will then affect the way future studies are going to be designed and the future standard of care that we are then going to be able to utilize for our patients. And the list goes on. Beyond STEAP1, DLL3, we have got TROP2, we have CD46, we've got FAP, we have got HER3, and it just goes on. And these are all very, very early in a preclinical development status. And again, it is also very exciting to look forward to these molecules and their effectiveness in clinical setting in the future. So I cannot end the topic without talking about radioligand therapy beyond first-line metastatic castration-resistant prostate cancer. Of course, we were exposed to the PSMA-4 and the RLT Pluto trial, but the best set of evidence that we have for the use of lutetium PSMA therapy today is from the VISION study for patients who have received prior taxane and ARSI. Lutetium PSMA 617 improved overall survival as compared to what was then offered to be a standard of care. But we don't just have a PSMA 617, we do have the PNT2002, which is a different molecule that is then coupled with lutetium 177. And this is, again, a very important molecule to be identified. And SPLASH is a study that looked into lutetium PNT2002 as compared to enzalutamide abiraterone. And this was, again, a positive study. And the same molecule that is actually developed by a different company, which is called PSMA INT. Again, a similar setup of lutetium versus ARPI. And this study is actually ongoing. And we've got more exciting molecules that are actually coming out with a combination of PSMA INT with actinium, or a PSMA 617 with actinium, and a PSMA with trillium, and actinium with J591. And these are all radioligand therapies that are up and coming, and they will definitely significantly alter the landscape of castrate-resistant prostate cancer in the future. Again, radium-223 is not something that we cannot ignore. LSIMCA was the first study that actually showed the evidence for the use of radium-223 in patients with bone-predominant disease in prostate cancer. And of course, radium-223 in combination with a PARP inhibitor such as Incomrab actually shows that the results are quite promising as a whole. So in conclusion, sequencing first-line treatment in castrate-resistant prostate cancer depends on the treatment that were actually used in the hormone-sensitive prostate cancer space. Strong evidence for treatment recommendations exists for patients who have received prior ADT with docetaxel, and prior ADT with an ARSI in the hormone-sensitive prostate cancer space. However, treatment sequence after a triplet therapy in castrate-sensitive phase is unknown and is currently guided by best practice guidelines. Sequencing second-line therapy must be further individualized as the evidences are further blurred. And novel therapies are crucial to address the current gaps that we have in the treatment, and we look forward to more exciting moments in the treatment of prostate cancer in the future. With that, I thank you.